All right, Dr. Fitzgerald, I think we're ready whenever you are.
Wonderful. Welcome, everyone, to our general meeting. I am so glad to be here. Today, we're going to talk about an issue that is dear to my heart. When Emily and I were at the State Department of Public Health, we had a program called Talk With Me Baby. And it was based on the information, the incredible ability of the new baby brain to absorb information. We learned in that program, and we worked on that program, that the number of times a parent talked to their child influenced the number of words that child learned. And at 18 months, you could measure that number of words, and you could predict from that number, the number of words that child would know at age 3, if nothing changed. And you could predict from that number, the number of words a child knew at 3rd grade. And from the number at 3rd grade, you could predict the chances of that child graduating from high school. And from the ability to graduate from high school, you could predict if that child was going to have a healthy and, quite frankly, wealthy life. So those early influences are hugely important. Jack Shawcroft at the Center for the Developing Child calls that early brain ability plasticity. We know the importance of it, and we know the profound effect that early stage can have on a child's entire life. We also know that if there are negative experiences, that can be problematic. And if there are interactions in that plasticity stage, there should be the ability to greatly influence the negative influences in that child's life. So today we are very excited to hear from the leaders in the field about the new information that we have learned, that we now know about early brain development. And we are so excited for this review. And I think we should just get started. And Emily, the first person we have on the agenda is Dr. Emily Graybill. She is the Associate Director and Director of the School and Communication Support and a Center for Leadership and Disability, and a clinical assistant professor at the School of Public Health at Georgia State University. And she's going to give us an overview of early brain development. So Dr. Graybill.
Thank you so much, Dr. Fitzgerald. I'm honored to be here today and to provide you with a very brief overview of infant and early childhood mental health and infant and early childhood mental health services, and then look forward to the speakers that follow me, who will provide some information about the work that's currently happening in this space in Georgia. We're getting the PowerPoint loaded. Great. Thanks, Emily. And I'm going to go ahead and turn off my video just so the focus can be on the screen. And I'm going to set my timer because I know we have a great list of presenters and want to make sure that I don't cut into anyone else's time. Okay, so we'll go ahead and get started. As was mentioned, my name is Emily Graybill, and I'm with the School of Public Health at Georgia State. I'm going to be just providing a very, very brief overview of infant and early childhood mental health today. This is a big field with a long history, so we'll just cover a few highlights today. Go on the next slide. So the learning objectives for today, the content that I'll cover are going to align with these two learning objectives here. So first, understanding infant and early childhood mental health, and then second, understanding infant and early childhood mental health services. You can go to the next slide. So the first, what is infant and early childhood mental health? And we can go to the next slide. So there are two definitions on the slide. You can see the first one here. And this first definition is from the World Association for Infant and Mental Health. And it notes that IECMH is the ability of children to develop physically, cognitively, and socially in a manner that allows them to master the primary emotional tasks of early childhood without serious disruption caused by harmful life events. Because infants grow in a context of nurturing environments, infant mental health involves the psychological balance of the infant family system. Then the second definition here is from 0 to 3, and it notes that IECMH is the developing capacity of the child from birth to 5 to form close and secure adult and peer relationships, experience, manage, and express a full range of emotions, and explore the environment and learn, all in the context of family, community, and culture. So I like to share both of these definitions and highlight that there are two components of these definitions that are particularly important. The full definitions are certainly important, but there are two components that are particularly important. And first, that IECMH is concerned with building that social emotional competence in young children. And then second, the field of IECMH recognizes that that social emotional competence is built through child caregiver interactions in a healthy family environment. So again, both of those definitions highlight those two critical components of infant and early childhood mental health. You can go to the next slide. So there are many variables that influence infant and early childhood mental health. And here are just four of the more influential variables that I do like to describe. And I'll go a little bit deeper into each of these variables on the next few slides. You can go to the next slide. Okay, so temperament. I know that this group is well-versed in many of these areas. So we know that temperament is the way a child approaches his or her environment. So how the baby or how the child approaches the world. And a common way that we hear temperament organized is according to easy, difficult, or slow to warm temperament. So if we've been around a lot of children or raised our own children, we can probably categorize the young children that we knew into one of these three categories. And maybe we knew enough about ourselves, heard enough about ourselves when we were young children from the people who raised us that we have a sense of what type of temperament we had. So easy infants and young children are thought to be more adaptable, enjoy social interactions, enjoy new experiences, whereas infants that are thought, and babies and young children who are thought to have a more difficult temperament may be more irregular in their moods or may be more sensitive to changes in their environment. And then finally, the slow to warm infants and young children may adapt more slowly to new situations or may withdraw from interactions that are overstimulating. So the opportunities for social emotional engagement and then therefore the social emotional development of young children can be influenced by differences in temperament, or by simply having a temperament that invites strong relationships with caregivers, or having a temperament that makes those strong relationships just a little bit more work. So again, if you think back to the children in your lives, you can probably think of children who really drew you to them. And then there may have been children who were not as open to that deep, intense social emotional interaction. I remember a family that I worked with who had a 4-year-old who could be described as having maybe a more difficult temperament. And the parents would describe the frustration over the child's, the words that they used were always ruining everything. So there would be, family interactions, family play dates, family meals, situations that they would set up that they thought were going to be very positive for their child. And the child would respond by becoming upset and angry and then acting like an upset and angry 4-year-old. So some of the strategies that were suggested were for the family to sort of step back, assess the child's threshold for stimulation, notice cues when the child was starting to wear down, and then find activities that were totally enjoyable to the child from start to finish and intersperse those activities with ones that the family had organized. So it's an example of how temperament, the child's temperament, can influence the child caregiver interaction. And so a child who presents this way could in some situations be punished just for sort of being who they are. Then the second variable that's listed on this slide, which we know impacts infant and early childhood mental health, is attachment. And again, I know you are deeply familiar with these terms, but attachment refers to that quality of the relationship that young children have with their caregivers. And so we know that in a healthy attachment relationship, the caregiver is going to recognize the unique characteristics of the child, like the child I just described. And then the child also recognizes that the caregiver is someone that they can turn to for comfort, if they're stressed or scared. So both of these variables are important and influence the social emotional development of young children. So we can go on to the next slide. Then we also know that parent stress, family stress, situational stress, and maternal depression can also influence the social emotional development of young children.
We know that parents experience stress for a range of reasons. We all experience stress for a range of reasons. We have our financial stress, our relationship stress, we have job stress. Some of us may be caregivers for parents at the same time we're caregivers for children. And we have, substantial evidence that suggests that parenting stress does negatively affect the relationship within the family, including that parent-child interaction. So one aspect of infant and early childhood mental health supports is to identify and reduce parent stress so that the parent stress does not have a long-term negative impact on the child's social emotional development. So the second variable that's listed on this slide is maternal depression. And again, there's a substantial body of evidence to suggest that there's a strong relationship between maternal depression and poor social emotional development. And maternal depression really can impact that attachment and then other areas of development and contribute to long-term behavioral challenges. And so again, any approach to infant and early childhood mental health is going to, really require attention to maternal mental health. We can go to the next slide. So it's not just maternal depression that can impact children's social emotional trajectory. There was a study that was published recently looking at the relationship between teacher depression and teacher requests for expulsion from classrooms. And this was a study that was conducted in childcare centers that were not affiliated with Head Start, and they were not affiliated with a public school system. So there were two really important results of this study that are listed here. So first, the teacher requests for expulsion were significantly positively related to teacher levels of depression. So in other words, the more depressed teachers reported they were, the more likely they were to request expelling a child from their classroom. So then the next set of results that are important, and this may be my favorite thing that I say all day, because I think these results are really important for the work that we all do. The relationship between teacher depression and student expulsion was moderated by the center's use of an infant early childhood mental health consultant. And so what this means is that when centers receive consultation from an infant early childhood mental health consultant, higher levels of teacher depression were not associated with an increase in the teacher's request that the student be expelled. When the centers did not report receiving infant early childhood mental health consultation from a mental health professional, higher levels of teacher depression were associated with increased expulsion rates. So this is a study that's on the smaller side. You can see that it involved 97 teachers, and so it needs to be replicated. But I think these are some great preliminary data that support the impact of infant and early childhood mental health consultants on children's outcomes. We can go to the next slide. So mental health concerns in infants, toddlers, and preschoolers do look different from mental health concerns in adults. We know that. And the early signs of mental health concerns in young children are often referred to as behavior problems, or a child may be described as struggling with emotional regulation. So on this slide, and then the next slide, you'll see some potential signs and symptoms of early mental health concerns, right? Thank you. This is the list of signs and symptoms of mental health concerns among preschoolers. And none of these signs and symptoms are diagnostic indicators in and of themselves. So if a child's demonstrating one or more of these, that doesn't mean definitely that they have a mental health concern, but that if they are presenting with one or more of these signs and symptoms, it could be worth following up with a professional to confirm that the family and child don't need additional support. And then also it's important to be aware that many of these behaviors often trigger punishment on the part of adults. And so why it's just so critical that when a child is presenting with one of these signs or symptoms, that we look deeper into what that child is trying to communicate before punishing them. All right, we can go to the next slide. Okay, so what are infant and early childhood mental health services? You can go to the next slide. So infant and early childhood mental health services and supports can be organized using our public health model of prevention. And we use this model of prevention to organize services and supports across many different systems, including healthcare and education. So I think, again, you all are probably pretty aware that the promotion, prevention supports and services are those universal supports. And so they are available to everyone, across the population, that's the target. And these types of supports are going to look different depending on the context that you're in. So universal supports within a community may look different than universal supports within a childcare setting, that look different from universal supports within a school, a K-12 school setting. So certainly the context is going to inform what the specific support looks like, but that first tier does include universal supports. Then the next tier of intervention that we talk about are those targeted supports. And this is what we think of when we talk about early intervention. And so these are supports that are targeted to families and children who may show some sign of risk. So there, maybe risk is defined based on a sociodemographic characteristic, like is used often to qualify families for home visiting services for some of our home visiting programs. Children may have a suspected or diagnosed developmental delay, and that may qualify them as at risk and in need of more targeted supports. And then finally, we have our treatment level, and this is our intensive level of supports. And this is where you would see then the mental health, clinical supports provided by a mental health clinician. And so certainly there are different levels of support even within the treatment tier, but again, this is where you would see our licensed mental health clinicians providing their support. You can go on the next slide. So here's an example of how infant and early childhood mental health services could be embedded into an existing system. And so this was a longitudinal study of the impact of IECMH and early Head Start home visiting programs. So in this study, families were randomly assigned to either IECMH home visiting services or to other home visiting or related services. So the home visitors providing the IECMH infused home visiting services, they were trained in IECMH, they had ongoing reflective supervision, and then they really focused their home visiting services on building that healthy relationship between the child and the family. So the families in this study began receiving services when their target child was 1, and they received those services until the target child was 3. And then their outcomes were assessed when the child was 5, and then again at 7. And the results of that longitudinal study did suggest that mothers and caregivers in the infant early childhood mental health home visiting group reported very positive outcomes, healthier family functioning, better family relationships, coping skills, less stress, et cetera. So again, an example of how IECMH is able to be infused into services that we know. Great, you can go to the next slide. Did I lose sound? No? Okay. So sometimes there are questions about who the patient is in IECMH work. And so the focus of IECMH services really is on all 4 of these components: the child, the caregiver, the environment, and then the relationships across all 3. And so because IECMH services are multidisciplinary, interdisciplinary, any professional that's going to work with families with young children can receive additional training on how to promote positive relationships between the child, the caregiver, and the environment. And so there are absolutely a need, here's my timer. All right, I will wrap up quickly. A need for licensed mental health clinicians who have that deep training on how to provide clinical mental health services to families. And then there are also IECMH trainings and endorsements for other disciplines that interact with families and young children. And so just to kind of give an example of how this could look, and then I will wrap up. So, if let's say you have a physical therapist who is working with an infant that might have had a nerve disruption in their arms. So that physical therapist would be primarily focused on promoting activities to keep the child's joints and muscles moving and to prevent the muscles from and joints from tightening up. But the physical therapist who is trained in IECMH would also be paying attention to how that injury could disrupt the relationship between the child and the caregiver. So for example, the child's motor challenges may impact the cueing or the gesturing that a child does that plays a real key role in how that parent-child dyad relates to each other. And so if that is affected, then the physical therapist would be attuned to that and could provide suggestions and coaching to the parent for how to engage a child differently to compensate for some of those deficits presented due to the injury. So the focus wouldn't be solely on the motor deficits and the motor development. There would also be a recognition that a delay or an injury in one area of development can impact then social emotional interaction and making sure that that the physical therapist is attending to some of those other areas of need as well. Okay, we can go to the next slide. So this is a good place to wrap up quickly. Why are IECMH services so important? Again, I don't know that this group needs to, you can go to the next slide, needs a whole lot of convincing that this is important work. We know that a high percentage, too many children experience social, emotional, relational, or behavioral concerns, and certainly families who live, or children who live in families that experience loss or substance use or severe mental illness or trauma are definitely at heightened risk of developing social, emotional, behavioral concerns. So again, this group knows about the impact of trauma on child development and on adult outcomes. And like it says on the slide, young children are especially vulnerable to trauma exposure because their brains are rapidly developing those first few years of life, as Dr. Fitzgerald mentioned. So all the reasons on this slide are why we do this work. I do like to note that we also do this work because our children and our families deserve to be happy and to be raised in nurturing environments. And so we certainly want to attenuate the effects of trauma on individuals, but we also just want to ensure that our young children and families are living happy and productive lives full of meaningful and supportive relationships. So those are the reasons why this work is important. So I will, the next slide is references. So I will turn it over to the next presenter. Thank you all for listening.
Thank you so much, Dr. Graybill. I think the most interesting thing for us with our work is your comments about the necessity or the usefulness of somebody being trauma informed in every single aspect of interaction with a child. That was very interesting. And would love to explore with you in the future some ways that you can suggest what kind of training needs to be universally available. That was most interesting. Thank you so much.
Thanks, Dr. Fitzgerald.
And our next presenter is Laura Lucas. She is the Infant and Early Childhood Mental Health Director with the Georgia Department of Early Care and Learning. And she's going to be talking about building an early childhood system of care for the social emotional health of young children in Georgia. So, Laura Lucas.
Thank you so much. And thank you so much, Dr. Graybill, for giving us such great foundational information to start our talk off today. We are talking about infant early childhood mental health and what we're doing in Georgia. Go on to the next slide. So I'm going to take you back a couple years to when an infant and toddler social and emotional health study committee was formed. And many of you are familiar with that. Some of you may have even presented on that committee because they had a lot of local expertise and national expertise come in and really talk about the importance of focusing on the 0 to 5 population and making sure that you have a system that supports their social emotional development. So out of that House Study Committee came some key recommendations. So what I'm going to do today is basically just quickly review those recommendations and just talk a little bit about some early steps that we're taking in Georgia to address these recommendations. So really the first step is establishing state level leadership in this area. So my position was established. I was hired in the middle of the pandemic, November 2020, so a little bit difficult. But as all of you, I'm getting used to hosting Zoom meetings. But it was sort of a big deal to have a position at the state level, really just focused on infant early childhood mental health. So I'm very humbled to be in that position and happy to lead the work. But I cannot do it by myself. So we established an infant early childhood mental health task force where all the child serving state agencies come together to talk about infant early childhood mental health. And you'll be happy to know that we had our first meeting last month, and all the child serving state agencies were present. DFACS, Public Health, Department of Education, Behavioral Health, and Community Health. So we're just so happy to be hosting that level of leadership at the from DECAL to really move this work forward, because we need all of us to come together. So with the recommendations, there's kind of a few different areas that they focused on. And one of it is, of course, workforce development. We have to have the capacity to serve our young children, right? So one of the first goals is to establish core competencies for our early childhood workforce. And we have a plan for that already. We are working with GEARS, who you'll hear from in just a moment, and the Alliance for the Advancement of Infant Early Childhood Mental Health to bring an endorsement program to Georgia. Many other states already have this level of, or this credentialing system. In fact, I've talked to many people who moved here from other states who had this credential, and we're kind of like, where is this, level of endorsement in Georgia? So this is something that we're moving forward with. We're very excited about. We've established a board, which I serve on, and the meetings also began last month. So we're just in the very early stages. So stay tuned for more information about that, because our hope is that will affect really the whole workforce that's working with early childhood to bring in that credential and that competency. We also want to focus on our new graduates, folks that are in school, in the university system, to embed infant early childhood mental health education into the child serving education program. I know when I was in school, that was like maybe one chapter in the book, but not a total focus. And so we need to really work with our university systems to make sure that that information that Dr. Graybill went over is part of the curriculum and part of the just basic standards of folks who want to work with early childhood to know about the importance of social emotional health in young children. We also want to find some opportunities to train the current Georgia mental health workforce and best practices in this area. And then, of course, embed infant early childhood mental health in the quality rated program for child care centers in Georgia. Next slide, please. The other huge area, whenever you're trying to make system change or look at really just making an improvement for services for children and families, is financing. So the other big area that we're really approaching is determining potential pathways for Medicaid reimbursement. And we're kind of approaching this in a couple different ways. I have been working specifically with the Department of Behavioral Health and Developmental Disabilities and the Department of Community Health to just kind of baseline understand what our Medicaid system looks like right now, serving our children 0 to 5. And I think everybody kind of knows on the treatment end, kind of what Dr. Graybill was saying, sort of that dyadic treatment with that relationship focus. We don't have a whole lot of options here in Georgia, and we have less financing options for that. So we're really trying to focus in on that end and just figure out how we can finance this to make services more accessible for 0 to 5. And then we have partners in this. We have help from the Interagency Directors Team, Infant Early Childhood Mental Health Work Group, who is really supporting all of this work, but has specifically been a very great partner in reviewing what other states have been doing. There's been a lot of other states that have been successful with either changing their Medicaid plan or adding modifiers or just figuring out different pathways. So we're very interested to learn what we can from our partners and peers in other states and figure out what is the best pathway for Georgia. So I'm really impressed with everybody kind of being on board and talking about this and trying to move this forward. In other areas, working with OBs, pediatricians, hospitals to improve that screening, early identification, and resource linkages. I think we have some great screening practices in Georgia, but sometimes you may screen and find an issue, but then there's not a resource or a clear resource to link the family to, or then you hit a wall because you can't pay for it. So we want to improve that. We want to, again, create that system. And then, of course, seeking and applying for early childhood mental health grants that can be utilized to expand and train that workforce and strengthen the overall system. Next slide. So kind of backing up to my role, really in my position, I'm going to serve as the home for this work in Georgia and really try to build connections or bridges to other state child serving agencies and organizations to create that system of early care addressing the social emotional health of children 0 to 5 in Georgia. But that's not something that I can do by myself. That is something that I definitely need partners to do. DCAL is not trying to achieve every recommendation that I just listed. That's impossible. We need all of our state partners. We need community organizations to come together to build this system. Next slide. So again, that's why we really built that infant early childhood mental health task force with all the child serving state agencies. And really their role is to build and sustain a comprehensive and collaborative early childhood system of care in Georgia. And when I say early childhood system of care, what I mean is really promoting coordinated policy, collaborative service delivery to support the many young children with or at risk for social, emotional, and behavioral health needs. So again, it really takes all of us. We all need to kind of be at the table and start really focusing on this and talking about what we can do. And that's what the task force, that's what their role is. Next slide. So I'm a visual person, so everything I just covered is sort of here in this chart, and I wanted to kind of show you at the systems level how the work is kind of parceled out around infant early childhood mental health in Georgia right now. And I'll say before I explain this that my hope is I'll have a lot more circles and squares and arrows as we move forward with this work. But right now, this is what it looks like. Again, the legislative committee recommended the task force that's convened by DCAL, and then we're working to implement those recommendations. But again, as I mentioned, the interagency directors team is a strong partner because that group not only has state child serving agencies, but many community organizations that do great work in child and adolescent behavioral health. And this year, they, in their childhood, their system of care state plan, there was actually some recommendations around infant early childhood mental health that really mirror or overlap the recommendations from the Legislative Study Committee. So we have a partner group here in this work group that we are both working on similar goals, and we're going to work together on that. And then also I wanted to recognize GEARS, the Georgia Early Education Alliance for Ready Students, who you'll hear from in just a moment. Who started the Infant Toddler Coalition that have been working for a long time to really advance the health, social, intellectual, emotional well-being of infants and toddlers across Georgia. And then, as I mentioned, we have created the Alliance for the Advancement of Infant Mental Health Association Board, exploring those competency and endorsement credentials that we are going to try to bring to Georgia for our workforce. So again, I want this slide to grow and have many more connections. And that's really where you all come in. Next slide. So we all know that everyone who touches the life of a child can promote social and emotional well-being. And if you can look at all these areas here, pediatric healthcare, early care and education, home visiting, judicial system, policy, child welfare, early intervention, all of these should really wrap around the child and the family to make sure that there's opportunities for healthy social and emotional development. And then when there is a problem, it's identified early, and then there's a clear link to resources, including treatment if needed. So really, we just want to work with everybody to build this childhood system of care together. Next slide. So if you have any questions, or perhaps you heard something that you're working on too and you want to connect, please reach out to me. Here's my email and my phone number. We really are wanting to kind of be the home for this work and bring in folks who are doing the good work in Georgia, and we're still learning. We're still fairly new. at this. So we really want to connect with people as much as possible. So thank you for the time to present today. And I'll let the next presenter go.
Thank you so much. And we're really encouraged to hear about the coordination of the state services because that is extremely vital. Certainly Resilient Georgia is happy to be a partner with you because we too have dedicated a lot of our resources to bringing all the available resources in one place. So we look forward to working with you and thank you so much for what you're doing. And I'm so glad there's an official state position. That's just really good news. Our next presenter is Kaylin Wells. The Health Policy Manager of GEARS, which is Georgia Early Childhood Alliance for Ready Students. And so if you will take it away.
Thank you, Dr. Fitzgerald. So if all of you are anything like me, you've just listened to all of this information from Dr. Graybill and from Laura and thought to yourself like, wow, this is so important. This work focusing on early childhood is really what's going to change the world. At least that's how I felt when I first learned about infant and early childhood mental health. And so I've been tasked with sort of giving you some opportunities to take action. How can you, in your vast array of roles that are represented on this call, work to support young children and their families? So can you click? So I'm going to be talking about how can you engage your community, your organization, and yourself throughout your work in order to support young children and their families. So the first thing you can do is you can learn more about brain development. So as Dr. Graybill talked about, we know that the first 3 years of life are when brains are developing the most rapidly, and that's when children are building the foundation for the rest of their lives. So here are 3 resources. The first 2 are actually Georgia-specific resources, and then the third is a national resource that have a lot of really rich information about early childhood brain development. That really is the foundation for infant and early childhood mental health. What we're doing when we're talking about infant and early childhood mental health is helping babies' brains grow. So this is, these are 3 resources where you can learn more. Better Brains for Babies has courses that you can sort of sign up for. They're webinars, I guess. So you can go and sign up for a session and really learn more about early childhood brain development. Build My Brain is a course that you can take at your own leisure that was developed with this Rollins Speech School, I believe. And then 0 to 3 has just a wealth of resources across an array of different, not just infant and early childhood mental health, but more about parenting and early childhood education. So they're a really great resource. Next slide. The next thing you can do is as you're interacting with children and families, you can refer families to programs that support healthy development. So I've listed some of those programs here. This is not the full list. I just wanted to sort of list some of them. So Children First, Home Visiting, and Babies Can't Wait are all very targeted toward early childhood and really focusing in on supporting families. Medicaid, CHIP, TANF, and then WIC and SNAP are programs that just support the family as a whole and can help alleviate some of the stress that comes with, not having health insurance or not having enough income to get you through the month or not having enough food on the table. And we know that that stress can really impact caregivers and children. So if you'll click one more time for me. This is how you can refer families to those different programs. And so I tried to break it out, but this is just, a tool for you as you encounter families who might be struggling with different hindrances to brain development. Next slide. And then these are some other referral sources. DECAL has a SEEDS helpline, which is for both families and for childcare programs. So programs can call, or families can call when it's clear that a child is struggling with behavior. So it's both meant to support families, and then the childcare programs where the families are, where the child is enrolled. Healthy Mothers, Healthy Babies, I think they're on the line. They have a hotline that helps connect families to different resources. And then Help Me Grow through DPH also helps connect families to different resources within the public health sphere. Next slide. And then this one Laura touched on, but really thinking about what an early childhood system of care might look like within your local community. So many of you are already building collaboratives within your communities. And so this is really an opportunity to just focus in on early childhood. Maybe it looks like a work group, or maybe it looks like, you know, someday a big luncheon, maybe when we're allowed to gather again, where you bring together childcare, Head Start, pediatricians, home visiting programs, early intervention, behavioral health, judges, policymakers, and you have them all at the table and say, what are we going to do to ensure that young children, like Dr. Graybill said, are happy, that they are leading that their families are leading productive, meaningful lives, and that the children and families are existing within a, you know, ecosystem that really supports them. And so starting to think about what a system of care might look like on a very local level. And as you're doing this, think about engaging parents and caregivers as partners in that work. You know, I think that advocates have a lot of really great things to say. The state has a lot of great things to say, DECAL, you know, et cetera. But if we're not consulting with parents and caregivers, then we're not really doing the full job of connecting all of the different pieces that go into an early childhood system of care. Next slide. And the last thing is that you can advocate for little ones. So you can be an advocate for high quality, affordable childcare. You can advocate for social emotional screening and treatment for young children and their caregivers. You can advocate for paid parental and medical leave. We know parental leave really gives parents time to bond with their babies, really strengthening that attachment that Dr. Graybill talked about. You can advocate for access to family supports like home visiting and early intervention. And then generally just be an advocate for young children whenever the chance arises. So there's I think a joke that yours is always in the room to say, what about the young children? But all of you can be that, you know, that person. All of you can say, what about young children? What are we doing to ensure that young children are really being thought about in this context? So that's my call to action for the day. And always feel free to reach out. I didn't include my contact information, but I'll drop it in the chat. And thank you so much for having us today, Dr. Fitzgerald and Emily Ann and Resilient. Like this has been fantastic. Thank you.
Thank you so much. Gears continues to be a wonderful partner and obviously a leader in this field. Emily, I believe there is a position here for you if you will take over. Dr. Ball?
Yes, ma'am. I think Neha is going to introduce our activity to get everybody a little, you know, engaged. And of course, you have to be creative when you're on Zoom for longer meetings. So Neha, do you want to explain our activity?
Thank you, Emily. Good morning, everyone. I'm Neha Khanna, and I am a strategy and evaluation consultant at Resilient Georgia. I'm also a mom to a 5-year-old and 7-year-old, and my absolute favorite activity to do with my boys since they were little babies is reading with them. That's a special time that we look forward to every day, and all of us know how important that is for early brain development, but also just as a wonderful bonding activity between caregivers and little ones, 0 to 5-year-olds. So we thought it would be fun today if we could all take a moment to pause and remember and share a favorite book that we enjoyed reading when you were 0 to 5 years old, or a book that you and a little person in your life, a 0 to 5 year old, have thoroughly enjoyed reading together. And if everybody could take a moment to please flood the chat with your responses, please do participate. It's for a very good cause. In fact, three exciting efforts that Emily is going to share a little bit more about.
Yes, so thank you for flooding the chat. That was wonderful. And the exciting piece is our wonderful interns are going to take all of your book titles and purchase some of these books from one of our favorite sites that allows us to recycle, which I'm passionate about, but Thrift Books. And we're going to be donating them to 3 organizations that are really doing some innovative work in this space. So I wanted to call out the Early Childhood Initiative at the Community Foundation of Northwest Georgia in Dalton. They're doing some wonderful work and have been for years around this space with both Eat, Move, Talk, which is passionate to me because that was a program that came from my department when I was at Department of Public Health. And of course, Talk With Me Baby, which Dr. Fitzgerald mentioned earlier in collaboration with Hamilton Medical Center. And they're also working with DeCal on the 2Gen Innovation Grant in partnership with Kennesaw. I saw some Kennesaw folks on the call and other technical colleges in their area. So we're very proud of them. So some of the books will be delivered to them. We're also donating some to the Black Child Development Institute, and Neha is going to post a Strength Within Summit that they're hosting on April 29th. And that will provide trauma-informed care support for early education and child advocates. So we're very excited to highlight their work. And lastly, Friends of Refugees will be getting some books. And I'm not going to share anything more about Friends of Refugees because you are going to hear from their director, Jennifer Green, right now.
Emily and Neha, can I make a quick comment?
Yes, sir, Dr. Jane.
Hey, I would like to make a humble contribution to this book effort. If you could send me the address where I would just like to contribute $500 to this effort.
Oh, thank you.
Great.
Absolutely.
And anyone else is welcome. That's fabulous.
Thank you so much.
Yeah. This just warmed my heart. Looking at the names of all the books, Brenda, oh my God. I mean, it's what a wonderful idea.
Wonderful. Thank you so much. Yay.
Thank you.
All right. I love it. And on that high note, our next speaker will be Jennifer Green, and she's the director of Refugee Family Literacy Program. And if you will speak, please.
Hi, everyone. I am Jennifer Green from the Refugee Family Literacy Program. We are a 2-generational program for refugee and immigrant families. We focus on children ages 0 to 5 and their parents. And I think we have a slide with one of our students here. Yeah, there we go. So our program has nearly 300 students from 30 countries or language groups. And we have 2 locations, one's in Clarkston and one is in Stone Mountain. Right now we are operating through distance learning in many different forms. And I'm here today to as a partner and someone really wanting to learn more about trauma-informed care for young children. But I also come as a partner wanting to make some contributions to the conversation as I share how our staff has been working with families. We don't have formal training in trauma-informed care, but I think our staff has had some really good inclinations, especially as they engage children from refugee and immigrant families. And I want this to be an important part of the conversation. Georgia, I think, is now 8th in the number of English language learning children in the US. And so I want this to be part of the conversation as we engage families. So I want to be a conversation partner, giving input also as I hear more from you. And I'm so grateful for all that I've learned today already. So our program serves people like Zuleika and Yusuf in this picture. They're from Sudan and moved to the US after living as refugees in Egypt for a while. And so when families come to the US, often the husband goes straight to work, but a mother with young children has few opportunities for work or education because she lacks childcare or transportation or both. And then children typically don't have early learning opportunities because for many there aren't affordable or accessible options, or families just don't quite feel comfortable sending children away for the day to a place that only speaks English, not their language. And so as a result, there are many mothers and children who just stay at home while husbands and older children go to work or to school. And this leads to isolation and depression for many. A lot of parents just don't have options until their children begin kindergarten. Zuleika and her son were in this boat. So we started a program where parents can come and learn English and US citizenship and bring their children, their young children age 0 to 5 to school with them. So the next slide shows mothers go to their class each day from 9 to 12 to learn English and US citizenship. Up in the right-hand corner is one of our first-time voters. We've had many mothers be able to pass their citizenship test. We have 8 levels of English offered. And I think for a lot of these mothers, I mean, this is really their only time that they can be off duty as a parent. So this is really precious time of just connecting with other mothers, kind of opening up to what they're dealing with. As Dr. Graybill talked about, maternal depression is very common. And so this is a time when they can share with each other and receive support. And so while mothers are in their class, the next slide shows their children ages 0 to 5 are in our early childhood development program. It's in the same building. This is nice in case children just really need some comfort from their mothers or may need to breastfeed or just have some attention. Parents are right there. And then parents can also see how our teachers are engaging children. Our children engage children with lots of language. They've all been trained through Talk With Me Baby, and all of our teachers have also been through the Eat, Move, Talk program. And play. They're on eye level with the children, really talking to them a lot. And importantly, they're talking to the children in their home languages. This is true in the infant class all the way through the 5-year-olds. Now, this is a challenge since we have so many languages represented. We have over 30 languages in the school that our families speak. But we have a teacher coach, and we work with the Rollins School of Language and Literacy to use specific strategies in dual language learning. Of course, for us, it's not just dual language learning, it's many languages. How do we have some best practices in dealing with a hyperlingual context? And key to our success is our really wonderful staff who speak over 20 languages of our families. And so that's another way that we're able to do this. We understand how important it is to nurture and celebrate and stimulate home languages for children's brain development and also for their sense of identity, their family bonds. We know our society is constantly sending messages that the most important and that somehow they're inferior because they speak English as a second or third or fourth language, or that their parents might be inferior because they don't know English, all of that. So we want to put home languages front and center. And I think this can be a very important part of trauma-informed care. So in the next slide, you'll see at the end of each day, mothers and children gather together for parent and child together time. And look, we're going to have some new books that we'll be reading in these sessions together. Thank you so much. So for 30 minutes at the end of each day, we sing songs in various languages, we tell stories, we do activities, sometimes coach mothers and good eye contact with their children, using their home language. Many of them have been told, don't use your home language, go to English. So we want to say, no, this is so important. It's the language of the heart. This is also just a time for cuddling and enjoying each other. Many of our moms have many children, so this is really precious one-on-one time for them. And here we look at books together. So many of our mothers can't read the English words yet. And we want to say that's okay. In fact, it's even better if you'll talk about the pictures in your home language with your children and really make a time with books not intimidating or scary, but a really precious time of enjoying each other, and feeling good about books, and just learning how language sounds and what a book is doing. Often our mothers are also picking up on messages that they're not as good at parenting because they don't read English. So we want to keep giving coaching and encouragement right there in the class. So the next slide, these are just a few highlights of our program that we're excited to share with you and learn from you how we can keep bringing in more formal learning about trauma-informed care. And I know many other child care centers in Georgia are also wonderful places for situating further learning. And I want to end, the last slide is just a picture of our truly amazing staff who attend to children each day with such care, such good inclinations, and really drawing on their own experiences, and work so hard and work very intentionally to create a beloved community that, you know, benefits the children, benefits the mothers, and really benefits them as well. I was interested in what Dr. Graybill was saying about you know, attending to the well-being of our teachers, of our child care providers as well. That's an important part of what we do. So that's it. If there are any questions, I'm happy to entertain them, or I'll also put my email in the chat if you want to get in touch. Here's our website too. Thank you so much for all the great work you all are doing.
Thank you for being here. What a fabulous program. It's really wonderful to hear about it. And let us say to you also that Resilient Georgia, we worked from the very beginning to get resources for trauma-informed training, and we will be glad to help connect all the folks on your staff with those resources. Thank you so much.
Thank you.
All right, our next speaker is Jill O'Meara, Early Education Community Partnership and Projects Manager with the Georgia Department of Early Care and Learning. And she's going to talk about an overview of community impact grants with a focus on trauma responsive care grants.
Thank you, Dr. Fitzgerald. It's great to be here with you all today. I'm honored to join this amazing group of speakers. This opportunity is enjoyable to just listen and learn about so many valuable resources around early childhood mental health. And of course, anytime you can see those photos coming from Jennifer Green, it always puts a smile on my face. Jennifer and I have worked together on the Eat, Move, Talk project for a while, so it's good to see you. As Dr. Fitzgerald mentioned, yes, I will be providing an overview of DECAL's latest grant opportunities. And but it's important for me to note here that one of our community impact grant opportunities is focused on the results of Georgia's preschool development grant needs assessment. And for this needs assessment, DECAL identified 9 focus areas that address specific community needs. And one of those 9 focus areas is providing mental health services for the birth to 5 population and their caregivers. Next slide, please. So in February of this year, DECAL announced 3 separate community impact grant opportunities. We decided to bucket them all together for this particular opportunity, and we're glad that we did. These particular grants will be awarded to local communities across Georgia to improve services for children ages birth to 5 and their families. And funding for this grant, or these grants, is made possible by our $11.2 million preschool development grant, renewal grant that Georgia received in January of 2020. And this was coming from the Department of Health and Human Services and the U.S. Department of Education. The preschool development grant provides the state with a unique opportunity to strengthen system level framework and better align critical birth to 5 services. Next slide, please. So thinking about preparing these grants, it was important for us to really spend some time to structure the purpose of these grants around PDG. And not to mention, living in a pandemic has either created or more likely, or most likely, elevated emotional trauma for so many families. And we believe that all of these grant opportunities will give hope to communities who are looking to be creative and work collaboratively with other organizations to design projects that strengthen local supports and services, again, for the birth to 5 population across the state. Now I would like to highlight some of those key points around the purposes of these grants, and they include providing community level supports, increasing community collaboration, working to find innovative ways to address critical needs, support research and evaluation efforts to provide measurable and hard to measure impacts, and to develop a how-to or blueprints for activities that can be expanded or taken to scale across the state. Next slide, please. And here you will see what these 3 grant opportunities are. The funds range from $10,000 to $75,000. For the 2 that are shown in gray, the deadline to apply for those was last week on Friday, March the 5th. But for those were our 2 generation innovation grants that have been mentioned earlier and the trauma responsive care grants. However, the community transformation grants, those are still open, and interested applicants can still submit a letter of interest up until March the 15th. Each grant opportunity requires the creation of a collaborative team that will implement this work, and each grant requires a 30% match, in-kind match of funding and or services. Next slide. For the community transformation grants, the next 2 slides will provide a brief overview of basics and logistics. Next slide. For the basics, the funding cycle for this grant is 18 months compared to the other 2, which have a 1-year funding cycle. Faculty from Carl Vincent Institute of Government will be providing technical support, and potential grantees will need to submit a letter of interest. And based on the letters of interest received, DECAL will invite up to 12 communities to submit a formal application. In the LOI, communities will need to select one of the 9 needs to address in their proposed project. And the needs mentioned on this slide include 9 focus areas from the PDG needs assessment that I mentioned earlier. All right, so next slide for the logistics. Eligibility for all of our community impact grants include nonprofit organizations with a 501c3 and government entities. And you can see on this timeline, you can see the timeline here, sorry. And for more information about either the LOI guidance, a very thorough, frequently asked question document, and our latest webinars, there's a link here on this slide that you can click on to be able to find more information. Or you can just go to our website at decal.ga.gov and look under funding opportunities. Next slide. So when I was talking to Neha and Emily about coming here today to talk with you all about the community grant opportunity, impact grant opportunities, I didn't want to leave out a little bit of our previous work that we've done before with 6 communities across the state, working on our trauma responsive care, our trauma informed care grants, which we called our early learning leadership collaborative. So for the 2021 trauma responsive care grants that was mentioned on that other slide, this will be our 2nd round of trauma-related grants that DECAL offered to local communities. In 2019, with funding from Georgia's Preschool Development Grant Planning Grant, we offered our first non-competitive round to 6 communities, and those which we called that grant the Early Learning Leadership Collaboratives. And because that was a lot to say, we decided to make a change and switch a little bit from focusing on trauma-informed care, which is important, and we will provide tools and trainings to do that. So for this grant, we want to focus on the trauma responsive care grant for the 2021 cycle. The 6 ELLC grantees for the 2019 grant cycle we had, those communities were Bartow, Baldwin, Cook, Elbert, Evans, and Troop. And we learned a lot about what makes this type of work successful at the community level. And with our partners at Georgia State University, those communities designed projects to build community resilience to early childhood trauma. The ELLCs had 2 main objectives to meet. One was to build a cross-sector collaborative team that included representation from various organizations to attend trainings from Georgia State University Child Welfare Training Collaborative, and to develop with their team, collaborative team, to develop and implement a community-based action plan for the birth to 5 population, and that was focused on building a response to trauma. Next slide, please. This information has been compiled from collective projects implemented by our ELLCs, but I am sharing these with you as ideas and hopes there are communities that can put this work, put these to work in their own community to support the birth to 5 population. For communities who are new to becoming trauma responsive, we encourage them to let the community know what they're working on. Maybe we know things are different right now and people are not hosting events, but maybe a virtual event, or even create some signage that helps to promote the vision for becoming a trauma responsive community. Supporting opportunities to connect families impacted by trauma with community-based services. Distribute trauma-informed resources and books for teachers and young children. Offer mindfulness trainings to parents, home visiting partners, and teachers in childcare programs, Head Start, Early Head Start, and the school systems. And collaborate with organizations to offer trainings that will prepare teachers with children to work with children impacted by trauma. One of the projects that's not on this particular slide, but was very successful in our ELLC work, was putting together self-care kits for teachers and families, and providing an area of calmness or peace places for young children in childcare settings or primary and elementary schools. At the bottom of the slide, you see a link to a webinar that we recently hosted for anyone who was interested in becoming a trauma responsive community. And the webinar includes information about our trauma responsive care grants, of course, but there was an hour and a half there that was a training from GSU that included several video highlights from our very own early learning leadership collaboratives, and they were talking about their work. So we'd love for you to check that out. Next slide, please. And lastly, because DeKalb is a state agency that handles birth to 5 early childhood education in Georgia, I didn't want to leave you without some ECE resources. And some of these have already been mentioned today. Gears is here, obviously. But we wanted to make sure and leave a few more for anyone who is looking for data resources or early childhood, or maybe you want to know how to find high quality early childhood programs across the state. Here are some resources for you at our qualityrated.org website. And so we wanted to make sure and provide a few more just in case. Data tools and the Kids Count Data Center, of course, and then Voices for Georgia's Children. We were making sure that whenever we were providing information to the early learning leadership collaboratives, because they were building those collaboratives from organizations, we wanted to make sure that they knew to bring in their partners from early childhood and make sure they had some childcare or Head Start populations that were joining that team as well. And next slide, please. So if you were to have any questions about these particular grants, you can please feel free to reach out to us by using the email that you see here at communityimpactgrants@decal.ga.gov, or I can add my contact information into the chat box as well. So thank you for this opportunity to talk about our grants and our trauma-related work across the state.
Wonderful. Thank you so much. It is really, it's been very interesting to us as an organization to see the impact that grants can do, that people with some money, and not necessarily a huge amount of money, but they can, with a reasonable amount of money, accomplish huge results. So that's very exciting to hear about those resources. And we'll be glad to have on our website a link to you or to publish the results and the findings of your group so that we continue to share the information throughout the state. Thank you so much. And our last speaker is Kathy Brown Bragg. She's the project director for New Generation Infant Early Childhood Mental Health with CRIS 180. So Kathy, if you will speak.
Good afternoon, everyone. It's really been very enlightening to hear all the work that's being done in different departments. And even though I do work on with many of you on different task force, but it's always just refreshing to just be reinforced with the information. So I'd like to just kind of briefly tell you a little bit about what we're doing with our infant early childhood program at CRIS 180. And we have actually a 5-year grant with SAMHSA to be able to provide these services for our families. We provide wraparound care, coordinated services for children ages 0 to 12 years old and their families who reside in Fulton, DeKalb, and Gwinnett counties. And we really try to focus on providing evidence-based screening and assessments. We develop individual service plans for our families and children. We use child-parent psychotherapy along with individual therapy for children. And then we also assess and assist with medication management if that's the case. One of the other things we do, which I think is very important, is we provide individual therapy for our parents and caregivers. And we also provide parent training, skills training, just to improve the functioning within the family. The second part of our project is training, which is very important. We provide specialized mental health training for mental health professionals, early childhood teachers, elementary school teachers, and support staff, really to help them gain expertise in identifying and referring infants and young children for appropriate services and support. We provide, and I know this, I think this is what Emily Ann had mentioned in terms of observation and consultation. We provide both of those services in the classrooms with teachers. So we sit down with teachers, we will observe the classroom, what's going on with the class, not only looking at the child who has been identified and referred to us, but also the whole classroom, to look at the climate of the classroom and what's going on, and then being able to sit with teachers and giving them strategies and ideas on how they can best support this child and the family who's been identified, but also to support all the children to make sure that everyone is happy and healthy in the classroom. Emily, you could go to the next slide. I really wanted to focus on safety because one of the things that this is an area that we work with teachers as well as parents. And so we talk about rituals and routines and transitions because if you know that transitions can activate stress responses in just normal children or children who have not been identified with any kind of mental health or social emotional challenges. But for a child who has been traumatized, a transition can really be very disruptive. And it can be disruptive in the classroom as well as in the home. So we try to encourage teachers as well as parents to put visuals up in their homes. So we have staff who work with parents to put a schedule together so that children know what's going on and what to expect to, especially if that is an area where they are struggling with in the classroom. And I think one of the speakers, I don't know if it was Emily, had mentioned that oftentimes children are labeled and are disciplined because of their behaviors, but really it's about them really struggling with those transitions. So we try to give teachers the opportunity to talk about what they see and how those transitions impact the circle time, the lining up for lunch, the being able to go into the different areas within the classrooms, and how they can really help those children so they can make a smooth transition. We talk about using visuals especially for children who can't read. And so we encourage, we help parents cut out pictures and be able to identify activities that they are involved in at home so that they can put those things up in the house and posters and things. And those are the things we provide. We provide those type of resources for families because we know that many of the families that we're working with are not, don't have access to different supplies. So we supply them with all the things that they need to be able to create that environment in their home. The next slide. And again, as I said, we try to create the school culture. We're looking at the school culture because if the school culture is safe and predictable, then children feel safe and they feel they are feeling safe from harm. We have teachers talk about rules. We also do the same thing with parents. We have them talk about what are the house rules and how and what are the expectations so that when children are in those settings, they know that that's an environment that is good, that they feel safe in. And so if children aren't feeling safe physically, then they're not going to be emotionally safe. We know that trauma impacts children in a way that they are in that fight, flight, and freeze mode. So we know that that means that oftentimes children are coming into a setting and they don't feel safe. And so we try to encourage them to understand that it's not that they don't want to cooperate or they don't understand what the process is in the classrooms and at home, but really just being able to give them an idea of what trauma looks like for young children. And that's part of our training. We really try to train our parents and our teachers to be able to understand that our children don't often have the language to express themselves about what they're feeling. And so it comes out in various ways, whether it's tantrums, whether it's just isolation, however it comes out, we try to train them so that they can identify it and be able to understand the cues of children so they can prevent some of those behaviors that they're challenged with. The next slide. I wanted you to see this slide because I know that I think Jill just mentioned something about how they are trying to teach teachers about creating these calming corners. And if you notice that they're very simple, they don't require a great deal of supply. We provide all the supplies for families to be able to use these calming corners, to develop these calming corners. And what we're trying to do is teach the parents and the teachers to be able to understand and read the body language and know the cues and the triggers of children. And by creating these calming corners, if you notice, one is just a laundry basket with a pillow. So we try to address sensory things. We really want children to be able to know they can go into these places and it's not punitive. It's not a timeout location. It really is for them to be able to know this is a place that they can go. They can learn, we teach them how to breathe. So they know that when they're feeling a certain way, they can go into the calming corner. They can sit and there's feathers in there. There's like a boa. There's books. There's things for children just to be able to calm themselves down and then be able to rejoin the group. And same thing at home. We have parents who set these up in their homes so that they know, okay, when a child is, struggling, they can go, they know that they have a safe place to go to, and they know that it's a place that is not, as I said, is not a punishment. It's not for them to be isolated from the group or from their families, but in fact, for them to be part of returning back into the group activity or returning back into the home after they have been able to calm themselves. And those are things that our therapists will teach the children how to do, how to really handle their emotions. Our teams are consisted of a therapist, a behavior aide, a care coordinator, and a nurse. And the reason we have these individuals, because each one of them have a special role in terms of working with the parents and as far as identifying resources and helping those parents get resources. And some of those things are basic, whether it be help with transportation, help with food, help with supplies. As I said, we create those spaces for them because our goal is really to remove any barriers that they have to be able to have a safe environment for their children. We also know that in the classrooms, we provide teachers with water and snacks because we know that sometimes children need to be hydrated. So we're able to give them supplies and we have small teddy bears and things of those natures for the teachers because we recognize that teachers are under a great deal of stress and they need to be able to be supported. And I think someone else mentioned that in terms of being able to give and support teachers so that they will be able to understand. So with our training, it's a basic 2-hour training and it allows anyone in the community who works with children, caregivers, to be able to learn more about mental health, infant mental health, particularly how the brain functions, how the brain impacts children around attachment, many of the things that we already heard this morning. These are the things that we cover in our trainings. So they understand that it's not just bad behaviors, but in fact, children are experiencing a great deal of trauma and how that trauma plays out. Okay. These are some of the strategies that we try to teach not only, again, our parents, but our teachers to say, hey, practice what you want the child to do. You know, sometimes parents and teachers may think that, you know, children come to school already knowing certain things, and we know that's not always the case. So we try to tell parents and teachers, give children a chance to do a do-over until they're successful. It's just practicing and realizing, again, where their strengths are and being able to reinforce those strengths. We talk about giving them visual cues, because we know that trauma, how that impacts on the brain. So we help them to be able to say, okay, this particular item represents this particular cue, and this is what we're going to be doing as far as learning how to walk, or how we're going to move from one station to the other in the classroom. We encourage a lot of movement, a lot of rhythm, because we know that rhythm calms children. And so we encourage parents to do games that require rhythm with clapping and drumming. All those things impact and support children and give them a sense of security. Next slide. Again, we try to tell parents about ignoring the no's. Let's not use the no's. Let's give them an opportunity to have a sense of control and say yes to them. Let's focus on problem solving. And again, as I mentioned, offering them drinks and snacks, because we know that, that when we are dehydrated, we aren't ourselves. And so we try to encourage parents to make sure that children are drinking enough water and having snacks, healthy snacks, so that they can function at home as well as in the school settings. Next slide. And you notice that I have Band-Aids, and these Band-Aids, believe it or not, we supply parents and teachers with Band-Aids. And the reason we do that is because, when you're working with small children, they all, every little thing may bother them. And so they need Band-Aids. So when the therapist is working with children, we talk about Band-Aids, what's hurting them. And we offer them a Band-Aid. So they may have a Band-Aid on their arm, they may have a Band-Aid on their head, they may have a Band-Aid, on their chest, but it really is an opportunity for both parents, teachers, and therapists to really try to figure out what's actually going on and what's hurting them, whether it's an inside hurt or outside hurt. So that's why we get Band-Aids. It's just a fun way for us to be able to, for them to be able to get some of the attention that they want. And also it opens up an opportunity for dialogue, for them to really share what's actually going on with them. So sometimes, you know, they'll come in, they may say something like, oh, my arm hurts, but then that opens up the whole avenue of them talking about maybe something that happened at home or something that happened between them and their siblings or something that happened at school. So we just, you know, again, try to be able to open up a sense of freedom for them to be able to express themselves in simple ways. And we, you know, as we have the color ones, and we have ones with rainbows and different pictures, and we get them to select what it is that they want. The next slide. Okay. Thank you. I hope this information was helpful. I think that a lot of what we're doing at CHRIS was talked about earlier with Emily as far as brain development and how we use, as I said, parent-child psychotherapy, really looking at how attachment impacts children, how depression and anxiety in, as far as their caregivers and teachers impact child development. So again, thank you for the opportunity to share a little bit about what we're doing at CHRIS 180 in our infant early childhood program. And please feel free to refer children and families. Again, we work with families that live in Fulton, DeKalb, and Gwinnett counties. Thank you.
Wonderful. Thank you. It's really fun hearing about the practical ways to do things. I have a new grandchild coming, and we're going to have a reset center in our house. So that is just great information. Thank you so much. This has been a very good day. If anyone has a question, please just hit question and we will call on you because I think that we have had some really knowledgeable and effective presenters. And are there any questions? All right, seeing none, let me just once again thank all of our speakers and thank you for being here. It's a real joy in Resilient Georgia to hear from the many people who are working on the same things that we are passionate about. And again, we are absolutely dedicated to making sure that all of this information is readily available. So know that it will be on your website, and we will certainly put it on our website so that wherever people go, they can find this information and the great resources. Thank you so much. I want you to look at that face with Resilient Georgia beside it and know that is the best Max person in the entire world. And many of you recognize that's Emily's little boy. And for everyone, thank you so much and have a good week and a great day. Thank you.
Thank you.
Thank you, everyone.
Thank you. Bye-bye.
Thank you, Dr. Fitzgerald.
Thank you.